Dr. Sears, your child's study, when you find out the child has asthma, like you go from birth to age 5, what is the first line of defense you use on a child these days for asthma? Because I've had asthma my whole life and I've been through all the medications. And I'm just wondering what a child today takes from what I took when I was little. And Dr. Waserman, I've also seen in the news that allergists now test food allergies with an actual piece of food, which I think is playing by fire because of anaphylaxis. I just want to get your opinion on that. What do you think about that?
Okay, great questions. Malcolm first and then Susan.
The question of what to do when a child begins to wheeze is one of those very difficult questions. I should declare up front I'm not a pediatrician, although I spend all my life looking at children with asthma and following them. But I have great respect for people who are not quite sure what to do with a 6-month-old baby who wheezes when they have a cold. It turns out that most of our medications, particularly the inhaled steroids, don't do very much, and even the bronchodilators don't do very much. And the issue is, what's the outcome anyway? An otherwise healthy baby who gets a couple of colds and wheezes when they have a cold is very likely not to have persistent asthma. So we look a lot at what are the risk factors for persistent asthma, which are the children we really need to treat. And the risk factors, there are a number of them, but just summarizing, if there's a strong family history, that gives you a clue that this child may be going to develop more serious allergic asthma. If the child has a positive skin test, particularly to things like house dust mite, that is again an indication this is likely to be a problem. And from some of the other studies we've done, and I'm sorry if it sounds sexist, but girls are going to have more problem than boys. Boys more often tend to have asthma early or wheezing episodes early. They are more often allergic, but they don't seem to persist as much. Girls may have milder symptoms as children, but when they go through puberty, and it's probably hormonally related, are more likely to have persistent asthma as they get older. So you've got to weigh all these things up and say, how aggressive do we need to be? And this is where I think it comes down to the art of looking at the individual case and saying, let's be aggressive with our treatment because there's a lot of risk factors here for persistent asthma versus this is just a bit of a wheeze with a cold, let's not get too upset about it. So you monitor, you see how often it occurs, and if it's rare, you're not too worried. If it's happening frequently, the child who comes to the emergency room 3 times a year, that child is in real trouble. You do need to do something with it.
And what do you do?
So what do we do? In the young age, we're using the inhaled steroids right down to a very young age now, under a year of age. We don't often do that, but sometimes need to do that. So again, it depends on the severity and the risk factors.
So the lady who asked the question has persistent severe asthma, I would imagine,
yes,
and had it all her life. The question, I would rephrase her question. You've answered her question, but I would rephrase her question. How do you recognize someone who's going to develop severe asthma? We don't know yet, do we?
There are certain
I'm asking Malcolm.
Yeah.
Okay. Well, I can answer that from another study that I've been involved with for many years. In New Zealand, where I came from originally, I was involved in a long-term follow-up study of children who were born in the 1970s. And we followed them, and we've just recently seen these children as 38-year-olds. So this really is a long-term study. We were able to identify the risk factors of persistence of childhood asthma as being allergy, especially to house dust mite, having more severe disease, and we can measure that by lung function tests and responses to challenge tests, things that we call a methacholine challenge test, where we make the airways constrict. People who've got very twitchy airways are more likely to have persistent asthma. As I said, girls more likely to have persistence than boys, and teenagers who start smoking are going to have more risk of persistent asthma. So those were 4 independent factors that came up. So we can predict to a certain extent. There's a sense out there that most childhood asthma goes away, and that's true and false. Most mild childhood asthma goes away. More severe childhood asthma is going to be with you for life.
Okay, so we'll move to, thank you, Malcolm. We'll move to that question about food challenges and whether it's, just really
If I understood
daredevil.
the question, did you mean oral challenges with the food in question, not skin testing with fresh foods? Okay. Now, we do oral challenges probably under a variety of conditions, and obviously this is not for the faint of heart. You need to be physician supervised, ready to treat anaphylaxis. We've had lots of experience with it, and there's no question it's a very valuable technique. It's our gold standard in allergy because skin testing tends to be too sensitive and blood tests don't often give you the answer. So it is our gold standard, but it has to be done carefully. I don't need to do an oral challenge to confirm food allergy in somebody who's had a severe event and has a positive skin test. To me, that's a no-brainer. But sometimes if I'm uncertain, if the tests are sort of indeterminate, no clear answer, or to see if somebody has outgrown that allergy, it's important for me to do a challenge. The other thing that I see more and more of is that parents are afraid to feed their children certain allergenic foods early on. So it's not unusual in my clinic to see children with other allergies who come in, they have never eaten peanut, they have never eaten tree nuts, they're now 3, 4, 5, 6 years of age. I will test them. They have a positive test because they're allergic children and these tests are sensitive. How do I sort of, determine what's really going on? They've never eaten it and never had a problem. And there is where, often oral food challenges have to be done. So we probably don't do enough of them. It's important. We've got to get the expertise for a variety of reasons, but you're absolutely right. You can get into trouble, and it's got to be done under supervised conditions.
And we did have a public forum, and we may have others, on food allergy and anaphylaxis, but we can come back to that. It's a very important issue.
Hi. I have a 5-year-old at home who was tested for allergy before she was 4. She's been put on puffers before she was 1, and she's been put on singular when she was 2, right? So she's on puffers, singular. We know that she is allergic to dust and dust mites. My question is there anything else I can do? She's already taking singulars and the puffers, but she's at home now with bronchitis. So maybe, what else can I do? Yeah. Oh, I got rid of the stuffed animals as well.
So should we try Chris out first instead of the doctors here? You want to take that first, or you want to let the doctors? What would you say on your hotline to that?
Well, it all depends on what's been done already in terms of avoidance of triggers. So there's all kinds of things. You can call our helpline or email us. We usually, ask a whole bunch of questions about what possible triggers there may be and what can be done about it. In terms of, at this age you can also get a flu shot, so everybody in the family probably, it's a great idea, want to raise that as well. If anybody watches Rick Mercer, was an awesome rant on the flu shot, just this week actually, well worth seeing. So that's another good preventative measure, but there's a whole bunch of things that have been done in the household that might be helpful, and in terms of the medications, I'm not sure exactly what medications are prescribed, but that's a little more limited to that age group, but there are some possible things that could be tried as well.
Okay, Dr. Waserman?
Well, I would agree with Chris. Often when sort of you do have less control, a lapse of control, if there's a viral trigger, then, you've got to go back to square one, reevaluate the medications. You need an asthma action plan. You may need to add something else. Always evaluate the technique and how that medication is being used. Where I have a bit more of a problem is when, in a bit of a different circumstance, where children have medication piled on, yet they're not getting any better, and that's tricky sometimes. I mean, I have sort of been burnt a couple of times, missing things like reflux, which did not get treated appropriately. And you always have to keep attuned to other things that may be driving asthma if the medications are not doing the job that you expect them to do. So reflux, allergic rhinitis, big adenoids on occasion, all of these things may be contributors, you know. So it's a question of always going back and telling your doctor and reevaluating and seeing where you are. The sort of circumstance that you describe, I see a lot in daycare children, one cold after another, symptoms always, and you know, it's a rough time of life and it's a rough period of time, and you keep up with your doctor, and you know, it's all about medication and trigger avoidance in those circumstances.
Anybody else have comments? Malcolm?
Sorry.
Yeah.
What do you think of humidifiers?
I don't generally recommend humidifiers. Malcolm mentioned the issue of mold and mold sensitivity and house dust mite allergy, and all of these things are influenced by humidity. So, you know, you're going to be leading precisely to overgrowth of those allergens that may be important in certain asthmatics. And, you know, too much humidity is also irritant to asthmatics. So in general, I don't recommend humidifiers and I don't use them.
Malcolm, brief, because we want to entertain one or two more
Comment,
questions.
what can we do to deal with it at the stage when it's already developed is a difficult question. What we're trying to do with our research is to try and find out why it got to that stage and what can we prevent it with. And there's some interesting findings emerging now, that some of which have come out of studies of children raised on farms versus those raised in the cities. And now there's good evidence that the best preventative for allergy is probably owning a dog. Now that sounds a bit contrary, but yeah, actually 2 dogs are better than 1. So my used to be rather facetious advice on the way home from the maternity hospital, stop at the pet shop. I think that's good advice now.
So the thing about dogs or pets in the home is, if you're already allergic to a cat, you don't want to be near a cat. But when you're growing up, all the evidence seems to suggest that if you grow up on a farm closer to animals, if you grow up with a dog, early on, maybe a cat not as much as a dog, you may be less likely to develop asthma or allergies. And that's because of lots of things that the immune system starts doing very early on. But the window of opportunity is what we have to find out about. So we're not advocating, no Malcolm, nobody here is advocating bringing pets into the home when you're known to be allergic to them.
It's a funny thing, I heard Dr. Sears speak probably 10, 12 years ago, and I thought it was hilarious, and I don't know if he borrowed it from someone else, but he said the best way to prevent getting asthma is to choose your parents wisely. And
Hi. In the beginning, there was a question about side effects of inhaled steroids. What about side effects of oral steroids? I'm sure that many of us in the beginning had experienced hospital visits where our children were exposed to oral steroids, and how much is too much?
Yeah, so Malcolm started with this earlier on.
How much is too much? When you need oral steroids, you need them. And the advice I give to my patients is, if you think you're in trouble, take your prednisone and ask questions afterwards, because you can always stop it if you don't need it. But if you wait too late, you may have a tragedy. So we tend to say, if you are known to have severe asthma, and this is more the sort of adolescent and adult end of it that I deal a lot with as well, use it rather than suffer, but contact us and let's see what's going on, and we'll get you off it again as quickly as we can. There's no problem of a maximum dose that you mustn't exceed, but you do, the more you use, the more likely you are to run into side effects. And so we use whatever it takes to get the episode under control, and then we taper it as effectively, as rapidly as possible, but without letting it flare up again, because if it flares because you cut the dose too soon, and then you have to raise the dose again, you've ended up giving even more. There are many strategies we're now using with the inhalers that we can fluctuate or vary the dosage of the inhalers, which avoids the need to go on to prednisone. So there's, again, working with your doctor and understanding some of the strategies with the combination puffers, as well as with steroid puffers alone, can reduce the need for steroids. Use them if you have to, avoid them if you can.
Yes.
I just got two quick questions. One is, you mentioned about that beds are the worst place for the dust mites, and obviously washing the linens regularly and the mattress covers. What is your suggestion on how frequently you should change the actual pillows themselves and the mattresses? And my second question is, my son has a severe peanut allergy, and basically, we have no peanuts in the house, and my daughter, so for that reason, has never been introduced to them. And I'm just wondering what it is as far as if it's never been in the system, is that going to make her more likely to be allergic when we do introduce it?
Well, for dust mites, and we touched on earlier that it's generally a combination of as many measures you can do that tends to have the most effect, and it's not necessarily a well-proven benefit. But definitely, pillows are a lot cheaper now. Also for your neck, that's unrelated, but people generally don't replace their pillows as often as they should. And I probably replace mine every few months because they're about $10 now.
Because you're obsessive compulsive?
Oh, yeah. Compulsive. No.
Sorry, Chris, you'll never forgive me for that.
And then you can also encase the pillows and mattress in dust mite impermeable material, which is not cheap, so I don't recommend it to everybody. In fact, I don't even have it on my bed. They're about $200 to $300, and not even a well-proven technique. Keeping the humidity below 50 or 40% or so around that area. Dust mites flourish with humidity. Washing your bedding once a week in hot water. Removing carpeting. Those are probably the main things that help for dust mites. But yeah, definitely replace the pillows.
That's great. So the more general question, there was a specific question about introduction of, if you will, something you might be allergic to, how early or how not, and whether that does or doesn't prime the immune system. That's a more generally phrased question. Susan.
I see a lot of siblings of peanut allergic children who've never been introduced to peanut, only because it's just not present in the house. Is that child at higher risk of having peanut allergy by virtue of having a peanut allergic sibling? And the answer seems to be yes. Usually, for peace of mind, what I generally recommend is that that other sibling be allergy tested for peanut to see if there is sensitization, and this should be done before the child starts school. You don't want to sort of have a child in a school, system of unknown allergic status, and find out for the first time that there's been accidental exposure and a problem, and do you give them an EpiPen? So that child needs assessment because they are at greater risk just by virtue of the genetics and the environment and everything else that led to the peanut allergy in the first sibling. Now, when to introduce allergenic foods, how to prevent allergy, this is currently a black box. I mean, I've been at this now for quite a while, and I used to tell everybody no allergenic foods till the age of 3. You avoid peanut, you avoid tree nuts. Most of this has been, thrown on its ear. At this point, the American Pediatric Society, the Canadian, the general consensus is that there is no magic time to introduce to prevent allergy. In fact, what the data seems to be pointing to now is that earlier exposure may be better. And this is, probably the big study that came out of Israel by Gideon Lack, where he looked at Israeli newborns. The mothers eat peanut in pregnancy in the form of a candy called bamba. The children eat it as well. And these children had far less allergy when compared to a British cohort of children where the message was avoid, avoid, avoid. So, that is still sort of, it's up in the air in terms of when to introduce or whatever, but I find that in my own clinic now, I am not giving avoidance advice as a means of prevention or introduction advice.
So it's doubly difficult for you with the siblings, but this is an area of active research around the world, and Allergen has a program as big, maybe not as big, but almost as big as the child study, to study the origins of disease, and it's called CanFest. Dr. Waserman's part of that big team, Canadian Food Allergy Strategic Team. looking at all kinds of different things, including in the child study, but also outside the child study, at genetics, at exposures, teaming up with people around the world to see when's the best time to avoid or not avoid. We really need to study this more. But in your particular case, that's a very delicate question, and Dr. Waserman's advice is well taken. Test early on. Dr. Sears?
This also applies to other foods. Peanut has become the biggest challenge to us in many respects. But there are now quite a number of studies showing that earlier introduction of the so-called allergenic foods reduces the risk. An article came out just a few days ago from Denmark. The timing of first introduction to fish was critically important as to who became allergic and who didn't. Not too early, but not too late. So there's a lot we're learning about this first year of life where the immune system is evolving. And the general tendency seems to be expose earlier so that you induce a tolerance rather than avoidance, which might increase the risk of allergy later.
So allergy is just the other side of the coin of good immunity. And it's a matter of channeling that force to good, which he called tolerance, which immunologists call tolerance rather than allergy or sensitivity. And to induce tolerance is the key question. Once you have the allergy, you could still induce tolerance, but it takes a long, hard road, and Dr. Waserman and others are involved in giving food challenges in little bits, in increments, and see how far you can go in desensitizing and even developing tolerance. There's another researcher in allergen who's developed vaccines for cat and ragweed allergy. They're based on the same thing that induces the sensitivity, given in chopped up bits, not naturopathic bits, not homeopathic bits, but real bits, given the right way to the immune system, can change that around. This is active research. This is not yet ready for prime time. Sorry to say.
My question is about non-medical interventions. It's probably for Dr. Sears. Our children are spending more time indoors than any time in human history and are also less active than any time in human history. So I guess what are the links between inactivity and indoor time? And also, what is the potential for increasing outdoor activity as a non-medical intervention?
Excellent questions.
Great questions.
There's a whole wave of research around this, and I guess we were introduced to it about 7 or 8 years ago by one of our colleagues from the US, Tom Platts-Mills, who recently visited us. He said, the problem of why children are getting asthma is television. They're all sitting inside on these house dust mite-infested couches watching television instead of out there playing sport as they used to do. Now they're not watching television, they're sitting there texting and whatever else. There's a link between physical activity, obesity, and asthma, which we're trying to untangle. We not only have an asthma allergy epidemic, we have an obesity epidemic. This is not to say that everybody who's overweight is suffering from some sort of major problem, but we're seeing far more children developing obesity for all sorts of reasons. Women or girls with obesity are more inclined to be asthmatic than boys. Again, for some reasons, we're still trying to fathom that out. So I can't give you a clear-cut answer except to say exercise and physical activity and getting outside is good for you, and sitting indoors with television and texting is probably not good for you. But I'm speaking as a grandparent now.
So should we all move to, let's say, Perth, Australia? They still have asthma there.
No, I would agree with that. The other sort of simple things, make sure that, proper replacement of vitamin D. Low vitamin D has been associated with an increased tendency to allergy. That's an easy thing that could be done. Other things are just, simple. There's a small literature on nasal saline, which has become extremely popular as a means of viral infection prevention. This is not hardcore science, and I'm not pretending that it is, but you're asking for simple, non-medicinal sorts of interventions, and both of those, in addition, I think, to exercise and physical activity, are things that you could do as well.
Thanks. I think we have time for maybe 2 more questions, maybe.
Hi, this is a question for Dr. Waserman. You said that we should avoid over-the-counter cough medications for asthmatic kids. My son, he has more cough symptoms than wheeze as symptoms of asthma, and obviously when he gets a cold, his cough really exacerbates. So what medicinal measures can I take to at least make him comfortable at night so, he can sleep through when he's going through a period of cold?
My reason behind saying that is not that these things are particularly detrimental or dangerous for asthmatics. They are just not proper treatments for the inflammation that we associate with asthma. They may work because they are cough suppressants, but you've got to recognize that you're not treating the underlying disease. If the child has nasal symptoms, nasal allergy, then you treat those with a nasal steroid. Otherwise, you've got to optimize the asthma management as much as possible. Since cough is a valid manifestation of asthma, people think it's all about wheezing, but it isn't. I mean, cough is every bit as important a symptom and often more common than wheezing. So optimal asthma care, treat the allergic rhinitis if there's reflux or other factors, but, in general, cough suppressants will not treat the underlying, inflammation or causes of this problem.
So you may get a night's sleep, but you haven't taken away the asthma. That's what she's trying to say. Maybe one more question. Yeah.
Sorry, I just have 3 questions, hopefully quickly.
Oh,
can someone,
look at that. Boy, you're really taking it. Oh.
Can someone please speak to the idea of exercise-induced asthma? That's one question. The second one, is it a myth that a child can actually outgrow asthma? And if not, what age can we hope for a child to outgrow asthma? And the third question, my child who is asthmatic also suffers from severe seasonal allergies. So he's taking inhaled steroids, nasal steroids, and now our doctor's recommending allergy shots. How much is too much medication?
Yeah, a little bit on exercise-induced asthma. So you have to be careful that it's actually not just asthma that's out of control. So that happens a lot, that people say, well, I only really get symptoms when I exercise. Well, if your lungs are inflamed, maybe at rest you're fine, but when you exercise and really pushing your the aerobics, then you will feel the symptoms. So there's that, first of all. There is true exercise-induced asthma where you're absolutely perfectly fine, except when you exercise, during the exercise or shortly after, you experience symptoms. And there are some ways to help that with warm-up and cool down afterwards. Perhaps a bronchodilator, as long as you're not requiring it more than 3 times a week. But then it's also key to figure out maybe a daily anti-inflammatory medication would treat that as well. And especially if the bronchodilator doesn't do a good enough job, you're still having symptoms, then it might be really worth a trial of inhaled steroids twice a day for a few months to see if that helps.
Thanks. Malcolm?
Yeah, I just emphasize the same point, that while there is such a thing as pure exercise-induced asthma, most people who get symptoms on exercise get symptoms because they have asthma, and exercise is just one of the things. Because you're needing more ventilation and your airways are narrowed, your symptoms develop. Now, there's been a whole range of studies on super athletic elite athletes, as they're called, skiers and so forth, who get a very different form of asthma just with exercise because of the high intensity of the exercise, and it's something to do with the drying out of the airways, with the amount of ventilation they do when they're just exerting themselves to the max. But most exercise-induced asthma is a manifestation of asthma itself. You asked a question about growing out of asthma. I mentioned that briefly before, but mild asthma, there's about a 50% likelihood that it's not going to persist. And when does it desist? Usually mid to later childhood. If asthma persists into adolescence, it's almost certainly going to persist. So growing out of asthma is an early thing. You say, well, asthma is a genetic disease and the genes don't change. But the manifestation of how those genes impact and the environment in which those genes are expressed may change over time. So if you have a child with serious asthma, don't sit back and say, it's okay, he's going to grow out of it. You need to treat it at the time. And if they grow out of it, well and good. The majority of children with more severe asthma are going to be lifelong asthmatics.
And very briefly, Susan, about allergy shots for asthma, just very briefly, because we want to wrap up.
There are allergic asthmatics who do flare up in season, and you know, the usual armamentarium is intranasal steroids and antihistamines and leukotriene antagonists like Singular. Allergy shots are wonderful forms of therapy, okay? They immunomodulate, meaning they change the immune system over time so that you're no longer allergic to that substance. But there is a big caution in giving them to asthmatics. Sometimes they will flare up the asthma. Allergy shots, you know, are associated not only with big local reactions around the needle, but some people will have systemic allergic reactions to those shots as well. And asthmatics tend to tolerate those sorts of reactions less well. I do have some asthmatics on shots. They tend to be people who are extremely well controlled and who I generally do myself. So it's not something that's used in asthmatics readily. It's got to be done with caution, and it has to be done in people who are well controlled, very compliant, and on daily medication. There is a downside.
Yeah, and I would just add that, just as a general rule, shots for allergy, medications for asthma. The literature on shots treating asthma is very poor.
No, I would have to agree with that. I mean, if you look at any guideline, shots are given for rhinitis, for hay fever, for eye symptoms, for insect sting allergy, but it is not a primary treatment for asthma except under exceptional circumstances, extremely mild asthma where you're giving it mainly for the seasonal allergy.
So listen, we could go on and on. I'm sorry if your question hasn't been posed. You have time to meet with the panelists and catch them before they leave. I'm going to bring this to a close. I wanted to thank Drs. Malcolm Sears, Susan Waserman, Julia Brederevich, Chris Haramy, and the Halton School Board representatives, Jackie Oxley and Bob Sirocco, for coming tonight and join me, please, in thanking them. I'd also like to thank the Halton Region staff for their help with this evening, and thanks very much to all of you for participating in Allergen's third public forum as Diana gives out the gifts. Diana Royce is the managing director of Allergen, and she's the gift giver. So we're delighted that you've joined with us tonight. It's been a great discussion. Your questions are superb questions. They're the questions that we ask each other all the time at the most sophisticated conferences. It's a very sophisticated audience, very well informed. I hope we've answered some of your questions, but it's mainly to stimulate you and us to go further in the treatment and prevention of asthma. We also acknowledge our funding partner, the Canadian Institutes for Health Research, and our network partners for advertising, the Halton Catholic and Public District School Boards, the Halton Region Public Health, Asthma Society of Canada, Ontario Lung Association, Anaphylaxis Canada, TV Cogeco, radio station KX 94.7 FM, all have partnered on this. And last but not least, the Allergen administrative team, Jose Mengels, Diana Royce, April O'Connell, Carol Ridsdale, and last but not least, fantastic job to Lindsay Farzy. Thank you very much.